Hi, we're Group 9, and our project assessed the effectiveness of a brief behavioral and educational intervention on the self-management of prediabetes across different ethnicities. What is diabetes? There are two main types, type 1 and type 2. For the purposes of this project, when we refer to diabetes, we are referring to type 2 diabetes or adult onset diabetes. Type 2 diabetes occurs when the body does not use its insulin to properly regulate blood glucose levels. There are several different tests to diagnose diabetes, but generally having a blood glucose level greater than 200 milligrams per deciliter or having a glycated hemoglobin A1C test greater than 6.5% indicates diabetes. Type 2 diabetes is far more prevalent than type 1, with 90 to 95% of diabetics having type 2 diabetes. On the other hand, a prediabetic individual is someone who has a blood glucose or glycated hemoglobin A1C level that is higher than normal, but is not high enough to be classified as diabetes. We are particularly concerned with preventing prediabetics from becoming diabetic. Unfortunately, diabetes is highly prevalent in the U.S. Currently, 26 million Americans suffer from diabetes, and the incidence of diabetes in the U.S. continues to increase to astronomical proportions. Diabetes is also the seventh leading cause of death in the U.S. Furthermore, type 2 diabetes does not affect all populations equally. Certain groups in our population are at an increased risk of type 2 diabetes. For example, women are more likely than men to have type 2 diabetes. Hispanic individuals have the highest lifetime risk of all ethnicities for developing diabetes, though Asian, Blacks, and Hispanics are all more likely than whites to develop type 2 diabetes. Finally, older individuals are more likely to develop type 2 diabetes than younger individuals.
There are two aims for the purpose of this study. Aim 1 is to compare immediate outcomes between the non-Hispanic white group and the non-Hispanic black group in the DPP intervention. The outcomes to be measured are change in physical activity level, BMI, and weight loss. Aim 2 is to compare long-term outcomes between the non-Hispanic white group and the non-Hispanic black group in the DPP intervention. The same outcomes used in Aim 1 will be measured for Aim 2. Our null hypothesis is that there will be no difference in outcomes between the two populations. Our alternative hypothesis is that there will be a significant difference between the two populations.
We will use a prospective cohort study design to compare the effectiveness of the DPP intensive lifestyle intervention on BMI, weight loss, and physical activity across the two populations. The DPP is a randomized clinical trial involving about 3,000 participants at 27 centers who are at risk of diabetes. The participants are randomly assigned to 3 different interventions, and our study only focuses on the data of the DPP intensive lifestyle intervention. There are a total of 1,079 participants. They are mostly non-Hispanic white and non-Hispanic black populations who meet the criteria of prediabetes. They are at least 25 years of age with BMI above at least 24 kg per meter square, meaning they are mostly overweight and obese. Participants with diabetes, heart disease, and on antihypertensive drugs are excluded. The DPP intensive lifestyle intervention is a goal-based intervention where the goal is to achieve at least 150 minutes per week physical activity by brisk walking or activity similar to that, and lose at least 7% of their baseline body weight. Participants meet with their individual manager 16 times over the 24-week period and are introduced to skills related to nutrition, exercise, and behavior change. Thereafter, they meet the manager every 2 months until the end of the intervention. The outcome measures are BMI, weight loss, and physical activity. Participants self-monitor their physical activity every day during the first 24 weeks and then 1 week per month for the remainder of the trial. They are weighed in street clothes with no shoes on. Height is measured using a wall-mounted stadiometer. Each measure is taken double, and then the average is taken to calculate BMI. Body weight data are collected every 6 months. Self-reported ethnicity, age, and gender are collected using questionnaire at baseline. The outcomes will be compared for immediate effect at week 24 at the beginning of the intervention and long-term effect at a mean of 3.2 years. Data analysis is only focused on participants who have achieved the intervention goal. Chi-square test statistics will be used to compare the goal achievement as a function of age category, ethnicity, BMI category, and sex. Confounders and effect modifiers will be controlled for. Data will be interpreted using appropriate analytical tools. Our main focus will be on the differences found across the two ethnic groups, which will be presented in tables and figures and stratified by age and sex.
Although many interventions are starting to suggest and take into account the need for a cultural component, limited comparative analysis studies support or disprove the need for this. Our study aims to obtain data to validate the necessity of a cultural component in pre-diabetic interventions. In order to do this, we will compare efficacy rates across subgroups rather than just considering efficacy rates for the population as a whole. The results of our study can serve as a paradigm for cultural barriers that may be present in other fields as well. This study, along with further research, may cause an increased use of cultural components in interventions worldwide, thereby increasing efficacy rates for intervention programs.
This study will use the social cognitive theory as the framework to assess the effectiveness of the DPP intervention. Self-efficacy, or a person's confidence in his or her ability to perform an action, is considered to be among the most consistent variables associated with regimen adherence and health self-management behaviors. Subscales on diabetes questionnaires can measure a patient's self-efficacy. Cultures maintain different collective identities that define them as a group and delineate their common goals. Tailoring interventions to a culture's collective efficacy can benefit the patient. This study faces several limitations. We chose to only focus on non-Hispanic whites and non-Hispanic blacks. Certain minorities, like Hispanics, are at greater risk for diabetes than others, and a culturally sensitive intervention focusing on pre-diabetic Hispanics would be beneficial. Also, there was only data on physical activity, weight loss, and BMI. Other measures, such as dietary intake, would be useful for the study. Supplementary anthropometric measures, like skin fold tests or weight circumference measurements, along with new diagnostic tools, such as blood glucose monitors, could help obtain more accurate data on participants. The DPP dataset did not include a self-efficacy scale, so it was difficult to take into account the social cognitive theory. The DPP was only conducted in the US, and other countries are greatly affected by diabetes, including China, India, Russia, and Japan. Future researchers should plan interventions in these countries, making sure to be culturally sensitive. Thank you for your time in listening to our study. We hope that the development of more effective pre-diabetes interventions can reduce the number of those who develop type 2 diabetes.